Hello everyone, I'm Simon Howe from the Health and Wellbeing team at Public Health England, East of England, and today we have Michelle Haville, Programme Manager, Health Improvement, Drugs and Alcohol and Tobacco Division and Public Health England, Julia Sinclair, Associate Professor of Psychiatry at the Faculty of Medicine at the University of Southampton, and also Honorary Consultant in Alcohol Liaison at the University Hospital Southampton. And Mary Arnott-G, Lead Nurse for Smoking Cessation at Central and North West London NHS Foundation Trust. The webinar session will take the format of an introduction from myself, followed by a series of presentations from our speakers, followed by a question and answer session at the end, where everyone will get an opportunity to ask a question. Alcohol misuse and smoking are amongst the most significant risk factors contributing to ill health. In England, more than 10 million people drink alcohol at levels that could be harming them, and about 7 million people smoke. Many of them make frequent visits to our hospitals, which gives us a great opportunity to talk to them about their drinking and smoking, and how their health could benefit from making changes. Hospitals present us with a unique opportunity for 4 reasons. Firstly, the health of those people we see in hospital is often being affected by drinking and smoking. Second, hospital patients often expect to be asked about whether they drink or smoke. Thirdly, brief interventions about tobacco and alcohol use are likely to be more effective when someone's already engaging with us about their health. And finally, patients trust the advice that we give to them in our role as health professionals. And the clinical case for addressing alcohol misuse is strong. We know that drinking alcohol affects every major body system. It's been identified as a causal or contributing factor in more than 200 conditions, and we know that the more a person drinks, the more their health is at risk. For anyone who's a smoker, the single best thing they can do for their health is, of course, to stop. Smoking is the single largest cause of preventable ill health and premature death. In England, it's responsible for 16% of all deaths in people aged 35 and older, and is the single largest cause of health inequalities. This webinar focuses on the implementation of the Preventing Ill Health by Risky Behaviour sequence and the delivery of very brief advice for tobacco and identification and brief advice for alcohol to patients in acute hospital settings. So I'll hand over to our first speaker, Michelle Haville. Over to you, please, Michelle.
Thank you, Simon. Hi, everybody, and thank you ever so much for being a part of today's webinar. My name is Michelle Haville, and I lead Public Health England's support for the Preventing Ill Health sequence. So without further ado, moving on to slide 2, the plan for my presentation today is to look at the why, what, and how of the Preventing Ill Health sequence. That is, why is it important? What does it involve? And how can we implement it well? So slide 3 starts with the why. Why is this work so critical? And why is it one of 13 things that has been prioritised for action by NHS England through this sequence scheme? In England, more than 10 million people drink alcohol at levels that could be harming their health, and nearly 7 million people still smoke. And we know that this contributes to a significant amount of avoidable ill health, and that it places a substantial burden on our healthcare services. In 2016 to 2017, there were more than 300,000 alcohol-related hospital admissions. This is about 38 admissions each and every hour. There were also more than 500,000 tobacco-related hospital admissions, which equates to about 1 admission each and every minute. But for people who both smoke and drink, we know that the impact can be even greater. One study has found that smoking raises your risk of dying from a range of cancers by 8 times. But if you drink above the low risk levels and smoke, your risk goes up to about 12 times. And of course, the impact of all of this on the NHS is mammoth. Harmful alcohol use costs the NHS an estimated $3.5 billion annually, and smoking costs the NHS an estimated $2 billion annually. But what we know from the evidence is that this does not need to be the case. By talking to patients about alcohol use and smoking, we can make a difference to each and every one of these indicators. There's good evidence that alcohol identification and brief advice can reduce alcohol consumption, reduce alcohol-related morbidity, and reduce the use of healthcare resources. There's also really strong evidence that stop smoking interventions are effective for hospitalized patients, regardless of what they're admitted for. These interventions are known to be effective in reducing smoking-related morbidity and both smoking-related and all-cause hospital admissions, as well as reducing costs to the NHS. Now, because of the good evidence base for these interventions, the National Institute of Health and Care Excellence recommends that secondary care providers deliver both of these interventions to all adult inpatients. But as a National Health Service, we know we're not there yet. We're not delivering on this guidance. And we're not having the beneficial impact that we know that we could be. And that's why, using the Preventing Ill Health sequin, we want to move closer towards a place where all adult inpatients, no matter who they are, know what their drinking means for their health and are able to make informed choices about their alcohol intake. As well as a place where all hospital patients who smoke know what the best way is to quit and have access to this support should they want it. So that's the evidence. That's why the Preventing Ill Health sequin is here. But this is also just the right thing for us to be doing. When I talk to people like yourselves and other clinicians and healthcare workers, you don't tend to quote nice guidance to me, and you don't babble on about the evidence. You simply tell me that it's the right thing to be doing. That talking to patients about their smoking and drinking is simply the right thing for the patient and the right thing for the NHS. And to me, that's just a perfect response. So moving on to the what. This is on slide 4. So what is the Preventing Ill Health sequin and what does it involve? So the Preventing Ill Health sequin is about identifying and influencing behaviour change in inpatients who are increasing or higher risk drinkers or who smoke by providing brief advice and appropriate referrals. In the 2018 to 2019 financial year, it applies to adult inpatients attending mental health, community and acute NHS services. For acute providers, what this involves is shown on slides 5 through to slide 7. So formally, the Preventing Ill Health sequin kicks off in acute providers from the 1st of April this year. In quarter 1, which is April through to June, it involves conducting a systems audit to ensure that information systems can capture information on people's smoking status and alcohol consumption, as well as the interventions that are being delivered. It involves training staff to confidently deliver the interventions, and it involves establishing a baseline level of activity in order to allow for monitoring of change over time. Then, from quarters 2 through to 4, and of course beyond, the focus is on providing very brief advice on smoking and alcohol identification and brief advice to inpatients. So for the purposes of this sequin, this means asking and recording smoking status for 90% of adult inpatients, giving advice on the best way to stop smoking to 90% of inpatients who smoke, and referring 30% of inpatients who smoke for specialist stop smoking support and offering them all stop smoking medication. It also involves screening 50% of inpatients for their level of alcohol risk, and then giving the correct intervention to 80% of inpatients who are identified as drinking above the low risk level. So this means giving brief advice about alcohol to patients who are drinking at increasing or higher risk levels, and offering a referral to patients who are identified as possibly alcohol dependent for specialist assessment and treatment. So moving on to slide 8, which looks at payment for this sequin. So payments will be made quarterly throughout the year. In quarter 1, the payments are split between the 3 quarter 1 milestones. So this means to be eligible for the full payment, providers need to have completed the systems audit, the staff training, and also to have established a baseline. Then, from quarter 2 onwards, the payments are linked to providers' performance against the targets for the 5 indicators. So, for example, the 90% screening target for tobacco. And the payments are weighted evenly between the tobacco and alcohol interventions. So this means that there is 50% available for achieving the tobacco target and 50% available for meeting the alcohol target. So how can we do all of this and do it well? So for this final section of my presentation, what I'm going to do is to run through what needs to happen for each component of the sequence, and where possible to draw on advice and tips that I've received from other providers on what has worked well for them. So on slide 9 are some tips for getting started. So the first tip for getting things off the ground is to establish a cross-organisational project team who can lead this work. So for many providers, this has consisted of a project lead who might be a Sequin program manager, clinical leads including nursing and medical directors, alcohol and smoking cessation specialists, a pharmacist, someone from HR who can advise on organisational learning, somebody from data analytics and information governance, somebody from internal communications, ward managers and champions who can push this work forward on the ground, and often a local authority lead who can support identifying what the best referral pathways are. And the second tip is to establish a project plan that assigns responsibility for key parts of the sequence. So conducting the systems audit and making changes, delivering the staff training, establishing those referral pathways, and also the internal communications part. So these 2 activities have really helped to get providers started on this sequence. Then moving on to the systems audit, which is shown on slide 10. So the systems audit involves determining how data will be collected for the 5 indicators, so determining how the trust is going to be collecting information on people's smoking and drinking, and also the interventions that have been given to those patients. It involves making any changes that need to occur to enable quarterly case note audits, and also setting out a proposed approach for conducting those quarterly case note audits. So on the next slide is the information that NHS Digital will be collecting from providers on a quarterly basis. So at a minimum, this is the information that information systems need to be able to gather and report on for this particular sequence. And of course, these items come directly from the 5 indicators. Then on the next slide, there are some recommendations from providers who have already got good information and systems in place. So these providers would recommend ensuring that there are prompts for screening and data collection that are built into systems that staff are already using, ensuring that the interface allows for fast data entry, where possible providing a visual depiction of alcohol units to help staff to enter data on alcohol use correctly, automating the alcohol risk score calculation based on patients' responses to the screening questions, providing examples of brief advice scripts for staff, and also highlighting what interventions should be carried out based on the patient's information. So on the next slide is a good example from South London and Maudsley NHS Foundation Trust. You can see here that it prompts health professionals to ask the audit questions. It automatically calculates a patient's score, identifies the patient's level of risk, states what intervention should be provided to that patient, and links through to a structured brief advice tool that staff can access should they need advice on providing that brief advice to the patient. And on the next slide is an example from University Hospitals of Morecambe Bay NHS Foundation Trust. Here you can see that they've got prompts for staff to screen patients for smoking. They've got a script for providing brief advice on smoking, and they've got checkboxes for recording whether a referral was offered and made for the patient. Then moving on to staff training, which is on slide 15. So this component of the sequin involves identifying what staff members will be delivering the interventions and their current skill set, identifying who will require training, determining what the training will entail and how it will be delivered, determining when the training will happen. So the majority of training for this sequin should happen before the 31st of June, and also assessing how effective the training was. Now, it's worth noting that the two interventions that are being incentivised by this sequin are considered to be non-specialist. So this means that staff shouldn't need an in-depth understanding of tobacco dependency or alcohol harm in order to deliver these interventions well. So the next slide shows the e-learning resources that are available through the National Centre for Smoking Cessation and Training, and also e-learning for healthcare. So these e-learning modules should be all that is needed to equip staff with the ability to provide these interventions to patients. But also just to highlight, in about 2 weeks, we will be launching a brand new e-learning module to support the sequin. And this will cover both very brief advice on smoking and alcohol identification and brief advice, and will be about an hour in length. It will be specific to acute settings. It will be available on e-learning for healthcare's portal. And yes, it will be available before the 31st of March. So there's a screenshot here showing an example of what that's looking like. Moving on to slide 18, where we look at how to establish a baseline. So this milestone involves collecting required data for each indicator to establish a credible baseline level of activity. So for your baseline, do keep in mind that this is really intended to give you a reliable picture of what's currently happening in the trust. So in some cases, this may not be a whole lot of activity, and that is absolutely fine, but you do want it to represent what is currently happening, and this is certainly not intended as a test. In terms of methods, for providers that see more than 500 inpatients in a quarter, it's expected that at least 500 case notes are audited, and that the case notes should be selected randomly and from all eligible sites and wards from across the trust. Then for providers that see fewer than 500 inpatients in a quarter, it's expected that all eligible case notes are audited. So this recommendation and advice has been provided to us by data experts, and the reasoning is really to ensure that you get an accurate picture of current activity, but also to ensure that you've got the power in your sample size to be able to detect changes quarter on quarter, so that you can actually measure improvement. So it is an important recommendation. Moving on to slide 19. So the final part of the Preventing Ill Health sequin is about providing our evidence-based interventions to patients. So that is alcohol identification and brief advice, and very brief advice on smoking. So lots of providers nationally are already doing this, and they're doing this really well. So their advice on doing this successfully is to determine what staff will be delivering these interventions. So some providers are choosing to rely on their nursing staff, others are choosing to rely on medicine management technicians, others are choosing to get all of their staff involved and responsible for delivering these interventions. And all of these options are absolutely good approaches. It's just that you need to be clear about what the expectation is, and make this clear to staff, and have some way of holding people accountable for delivering these interventions. Consider how the interventions can be integrated into clinical pathways. Take time to engage staff, so have a strong internal communication strategy that will help to bring staff on board. Where possible, build the interventions into standard operating procedures for the relevant staff. So if you're using your medicine management technicians, try to build the interventions into their standard operating procedures. Ensure there's visible leadership supporting the interventions across the trust. If you have time, conduct a pilot to identify any hurdles and to provide a soft initiation for staff. Ensure staff have access to tools to help them with implementation, such as the screening tools, training, and brief advice scripts. Provide ample opportunities for staff to ask questions. Ensure that refresher training is readily available. And regularly monitor activity, evaluate impact, and feed this back to staff. Staff really do need to have an understanding of the impact that they're having for the patients and the organisation. So for those of you who have got access to the Skype version of this presentation, showing now on the screen is the fantastic results that the Whittington in London achieved from implementing a similar sequin just a few years ago. So you can see through these graphs that this work is doable, it is achievable, and we can do this and achieve fantastic results. And certainly as a wise respiratory physician from Leicester would say, there are always problems and there are always challenges, but let's focus on the solutions because we can do this, and when we do, the impact will be monumental. So slide 20 is about where to go for more help. So resources and guidance to support implementation are available on gov.uk. The web address is written up there, but you can also just type preventing ill health into the website. And you can direct any questions or queries about the sequin scheme to e.sequin@nhs.net. The British Thoracic Society have also recently published a quality improvement tool in order to support thinking about how we can use systematic processes to improve quality of care. So this tool focuses on smoking cessation, but I think that the approaches within the tool and the strategies that are used can also be applied to alcohol harm. So in summing up on the final slide, I just want to say that we know that brief interventions on smoking and alcohol that are provided by those who work in hospitals are effective and they save the NHS money. But most importantly, they make patients' lives better and healthier. And that's why providing very brief advice on smoking and alcohol identification and brief advice through this sequin is the right thing for us to do. It's the right thing for patients, and of course, it's the right thing for the NHS. So thank you for listening. I'm going to hand back to Simon Howe now.
Thank you very much, Michelle. We're now going to hear from Julia Sinclair about the experience of delivering the alcohol identification and brief advice element of the sequin at University Hospital Southampton. Please note that Julia will not be using slides, so I'm going to hand over to Julia now. Thank you, Julia.
Thank you, Simon, and hello, everyone. There is a link on the slides to the case study, which has already been written up, and I'm just going to kind of talk through that a bit, hopefully to make it come alive a bit, and happy to answer any questions about what we've learned and some of the challenges that we've had at the end of the overall presentation. So we've had a bit of a run into this in that it was back in 2015 that one of our pharmacists, who I think was really concerned about our one alcohol nurse trying to do all the screening that was required in the hospital, who kind of came up with this idea that we have medicines management technicians, and I'll explain about them in a minute, and that perhaps as part of their role, screening for alcohol could be incorporated into their seeing of the patient. And since that time, this has very much been led by, at the ground level, by Lindsay Steele, who is the manager for the medicines management technicians. So although I'm talking here today, she's the person who's been doing a phenomenal amount of work to actually really make this become a reality. So if I just say a little bit about the medicines reconciliation process for those of you who are perhaps less familiar with it. I mean, it's kind of defined as the process of obtaining an up-to-date and accurate medication list that has been compared to the most recently available information that the patient comes in with. So a patient comes in and they say, I'm on 2 white pills and a blue one, and how is it that actually the staff are able to work out what exactly they're in? So what they do is they make sure that there's an accurate record of what the patients are in, what they've actually been taken, so that patients can be continued on any medication as soon as possible within their hospital stay. And so the really important bit from the screening point of view is that the medicines management technicians actually tend to see the vast majority of people within the first 24 hours of their stay. And certainly within Southampton, but I believe in many places, much of this work is carried out by a medicines management technician, who I'll call an MMT for now, because otherwise it's a bit of a mouthful. But the role of the MMT really is to gather that information about what medicines the patient is on from either the patient, their carer, the relative. They might phone the GP, if there's already stuff on a recent hospital admission that will give us more information, they will do that. They, at the end of the patient's stay, also ensure that the patient has sufficient supplies of medicines on discharge. And while the patient's in hospital, they often also provide advice on how to take medicines, and they liaise with other kind of healthcare professionals if the patient requires ongoing follow-up support. So it's a recognised MVQ level 3 qualification that they have. And they're quite a core group in the hospital, and in our hospital we have about 35 members of the team. So it's a small team, but it has the advantage of the fact that it covers the entire hospital and pretty much sees every inpatient who is admitted. So we thought, as part of doing screening and brief advice, that could be a role that the medicines management technicians could undertake, and that they could then refer anybody who is at the increased risk drinking to our nursing team, and best use their nursing skills to deal with the more complex alcohol problems. So originally, back in November 2015, we ran a 2-week pilot, which was there for essentially 10 days, Monday to Friday, on 2 consecutive weeks. And I will talk a little bit about that. But also, we then got an extended pilot as part of making a business case for the trust, which has now been ongoing since July of last year. It was going to be July to December, and the trust has now continued to support that because the sequin is coming up, and so we have that additional support. So when I talk about it, I'm going to kind of roll those two things in together in order to ensure that it's just clear about the processes that we're doing, and it makes it easier to understand the learning that we've had from it. So the plan was that the medicines management technicians, the MMTs, would see all patients as they were admitted, and certainly in the first 2-week pilot, what they did was they would kind of, when they saw a patient, they would ask their usual questions that they did, and then they would say, I'd like to ask you some lifestyle questions. Do you mind if I ask you about your alcohol intake? As we know that with prescribing medications, it's helpful to know about people's alcohol intake. And then they would go on and ask the 3 Audit C questions, and based on the score that the patient then got, based on their answers to that questions, they would record the score. For the first 2 weeks was just on a piece of paper, which we then kept, but now it's actually electronically on the patient's electronic record, and they would then give feedback to the patient, and the MMTs have their own scripts. So if the patient is scoring under 4 on the audit, they will kind of obviously say something along the lines of, you appear to be drinking at lower levels at the moment, and levels are unlikely to be doing you any harm. If patients were scoring between 5 and 9, they'd give feedback as per the Public Health England leaflet, saying you're drinking at levels that increase your risk of physical and psychological harm, and reduce the amount that you drink is likely to have a positive impact. And key, I think, for this group, we also had a very nice leaflet which we could give patients, which not only gave them some more information about physical and psychological harms of alcohol, had a little drink diary as part of it, and gave them some signposting to various resources, not just local substance misuse ones, but also online ones. And so they would give that leaflet, and that had the added advantage is that then when the clinical teams came along and saw that a patient had one of these leaflets on their tray, it actually also further encouraged the clinical team to be aware of that alcohol may be a problem for this patient, and it might be something to factor into their management of them. And then obviously for patients who scored 10 or more on the Audit C, they had a similar piece that they said to them, They also gave them a leaflet, and they would refer them on to the alcohol care team nurses. They'd say, based on your score, as part of our hospital policy, we'd like to pass your details on to our alcohol care nurses, who will be in touch with you for a follow-up, and are you happy for us to do that? So that was the system as it was set up. And what we found was that in those kind of first 10 days that we did the pilot back in November of 2015, actually the 36 pharmacy technicians assessed 789 patients across 56 wards. They referred on 64 patients, so those are people who actually scored at higher levels or possible dependence. And the other thing they did, which was very sensible of them from a business case point of view, they worked out how much extra time that it took them, and they worked out it took approximately 6 minutes extra as part of their standard operating procedure. So that enabled us to make the business case to say, well, if we had one more pharmacy technician, all the additional pharmacy technicians could then incorporate this extra bit of alcohol screening into their role, and we could continue with that. And the hospital thought that was a sensible thing to do, and so has invested in that. I think it's important from the learning point of view from our side of things, which was that actually the medicines management technicians, just during that 10-day period, identified more than 80% of people they identified people who would not have otherwise have been picked up, and that was 80% more. So the nurses on their own would have only picked up 20% of those 60 people that they identified as having a significant problem. So that, for me, as a clinician, was a really important thing, was that we're missing lots and lots of people. From a challenges point of view, just to take you through those, there was a lot of staff uncertainty, and I think particularly at an organisational level, and I think Michelle's advice about getting HR involved is a really very important one, because you have, particularly with the medicines management technicians, and I think many staff, a sense of role legitimacy. Is it my job to ask people about this? And certainly, there was some real concern. So we set up quite a full kind of training program for the MMTs. We made it fun. They actually had time away from their normal work to enable them to do this. And training was really important in terms of kind of getting people to understand some of the cultural aspects of this. And the other challenge was where best to record this. And we now record it on the patient electronic record in with the comorbidities. And that has some real advantages, because it means that it gets pulled through onto the discharge summary. So the GP is also now aware of their audit score for the last time they come into hospital. The downside of that is that now that we have electronic discharge summaries, everybody wants their important thing on the electronic discharge summary. So the discharge summary is now about 4 pages, and when I last spoke to a GP, they said, well, there's so much on the electronic discharge summary, we can't actually now pick out the details that we want. So, I think that is a concern. And so I think that was one of our biggest challenges. And the other challenge, which is an ongoing one, is that the more people we pick up, obviously the more people our very small alcohol care team needs to deal with. And there is concern, I think, within the organisation about how we meet that extra demand. Just to say a little bit about the technician attitudes before, we did some really good surveying of them online, so it was a really nice opportunity for them to say what they think, and we've surveyed them at intervals since that time. Their biggest concerns, not surprisingly, was about role legitimacy, as I've mentioned. The extra time was obviously a key one. They're busy people, and how they're going to squeeze this in. And real concerns about kind of their competencies around it, their knowledge gap. How do I calculate units? If somebody says to me they drink a litre of X and I don't know what X is, how do I ask them about that? And, how do we have conversations, healthy conversations with people? So that was their concerns, and people said things like, well, I feel it's excessively intrusive. I'm concerned that some patients may be angry or unhappy with us for referring them onto the service. And so part of the training was saying, well, when you have patients with diabetes, part of that work is to refer them onto the diabetes team. There's not a stigma attached to that. So getting people to think about alcohol as in the same way they think about other conditions that people may come into. We also actually had one of our AA, Alcoholics Anonymous, colleagues who came to kind of run an AA meeting and sort of to give them an idea of that. And actually people found that incredibly powerful as a way of understanding that people who have a significant problem, just that 5% at the very top, may actually have find this intervention very useful. So when we then did the survey again after the initial pilot, as I said, we found out that it took 6 minutes per history taking. That was recorded at the time. Interestingly, there was quite a change in the attitude. Most people found were actually quite happy to answer questions. And somebody said, I was happy to run through it. However, I felt a little awkward handing out leaflets to patients who had only scored 5 because I think I probably drink more than they do. So, I think we have to address that head on, and it will be, I'm sure, the same for smoking, is how do we deal with behaviours in patients that we ourselves engage with? And that's a huge, wider question, I think, for us as health professionals. I think somebody else said, I think that we're well placed to be asking people about their alcohol intake, and that confidence and competence will develop with time and practice. And I think increasingly, particularly since the 6-month pilot, somebody fed back to me just last month, really, that, I used to feel really uncomfortable about asking people, but, now it's just the next question I ask. And the patients don't mind at all. And I said to her, so, what does that tell you about when you were first asking it? And she said, well, I think it was my concern about asking it than the patient's concern about being asked. So I think for us, the learning from that is, allowing people to express their kind of concerns, however legitimate or otherwise they are, about asking people about alcohol, but encouraging them to try it, and with the confidence asking about it, realizing that many of those concerns kind of go away. So in terms of the advantages of using the medicines management technicians, I think, it's a very sustainable way of doing things. They're a very stable workforce. And in fact, we found that when we ran the training for the second 6-month pilot, actually 60% of the people had already been there for the training at the first. So they're a nice, stable group. It's not like kind of medical staff and nursing staff where people often kind of rotate around much more. I think from the patient perspective, it has really good face validity. In terms of, somebody's just been asking about what medicines they take and side effects of those sorts of things, and then they go and ask them about another substance that they also take into their body. So, it has good face validity. It feels kind of very non-judgmental. I think the other advantage that we've worked on over time is linking it to the patient record, and this has a number of advantages. The more you can automate something, it will be helpful, obviously, for us kind of demonstrating for the sequin about who has been seen, because it's already there. It's not extra work that needs to be done now. It's incorporated. But as I said before, it also pulls it through to the discharge summary, which I think is a huge advantage, because it means the GP knows. The patient also knows, because obviously they're given a copy of their discharge summary. And it means that increases the awareness of the GP, the patient, and their family. And there were some real concerns when we started this about people not perhaps wanting to have, increasing use of alcohol or possible alcohol dependence. And, touch wood, but we've now been doing this, as I said, kind of full-time with all of our medical inpatients since July of last year, and we have not as yet had one complaint from a patient saying, why is this on my discharge summary? So I think, that is very positive. Benefits that we've seen is that the medicines management technicians have really become increasingly confident in their role with this, as I kind of demonstrated a minute ago with that feedback. But, they now feel happy that this is part of their standard operating procedure. This is part of their role. And so with that, obviously, their role legitimacy, has grown, and they now see it as core to it. I think with it, there's also part of changing hospital culture around asking people about alcohol. So there is that sense of if, everybody is being asked about their alcohol when they come in, it's not a big deal to ask somebody about their alcohol. It's just part of an important part of the clinical history that we take. And I think from the organizational perspective, we have therefore been much, much better about recording the number of patients whose alcohol use has an impact on the care that they might need in hospital. So the sequin is obviously designed primarily in terms of a prevention sequin and for future behavior. But as part of that, we will be identifying those kind of 5% of people who are alcohol dependent, who may well need medical assistance with alcohol withdrawals whilst they're in hospital. And so I think, there are two parts to this. Is that actually if we're better identifying at the beginning of somebody's hospital stay what might be their need whilst they're in, it means that when they develop an acute confusional state, hopefully the teams will be better prepared to think, oh gosh, yes, and they're drinking at high levels, it could be that they've gone into alcohol withdrawal, and treat that better. And that, for me, as a specialist in the area, is something that I think is really, really important. And I think it's also been helpful in selling it to my clinical colleagues, that this isn't just, and I use that kind of advisedly, about health promotion and prevention. It is also about direct clinical care and part of what we should be core part of our business. So next steps, obviously with the sequin coming, we're going to be looking to extending our coverage from the medical wards out to the surgical wards, trauma, cardiology, and the various other divisions within the hospital. And we're going to work locally to look at whether it's going to be possible to incorporate the smoking into this model without overburdening our staff. So I hope that gives you just an overview of that, and the case history is already there, the case study rather, is already there on the web, and I'd be happy to take questions later on.
Thank you very much, Julia. Our next speaker is, and our final presentation is from Mary Arnott-G, who will talk us through the implementation of the Stop Smoking element of the sequin in Central and North London West NHS Foundation Trust. So over to you, please, Mary. And I'll be moving your slides forward, so if you can say next slide, please, and I'll move them along. Thank you.
Hello, everybody. Yes, as Sam just said, I'm Mary Arnott-G. I'm the lead nurse for smoking cessation with Central and North West London Trust, which, as its name suggests, we cover 6 London boroughs. However, we also have both mental health and community services in Milton Keynes, which, of course, comes under the Eastern region. So I was at the meeting that Public Health England held at Cambridge. And if we can turn over, you will see the first slide is actually from that meeting, outlining the sequin. And as you can see, Mental Health and Community Trust, we're almost 1 year now into the sequin. It was 2 years for us, so we're coming to the end of the first year now. You can see there the criteria within the sequin, but if we can turn on to page 3, who is involved. For us, it applies to both mental health and community services within our trust, so that's trust-wide. We are a very large trust, and it's aiming to set out the objectives within the 5-year forward view, particularly prevention and incentivising and supporting healthier behaviour. This is particularly important within mental health because those of you that have seen the ASH booklet, Action, Smoking and Health, their booklet, the Stolen Years, people with serious mental illness are dying some 15 to 20 years earlier than the rest of the population because of physical health inequalities. If you can turn on to page 4, please. For tobacco, I'm talking about tobacco because I'm the smoking cessation lead nurse, but we also had the lead from our alcohol and substance misuse service that led on the alcohol element. But for the purposes of this presentation, I'll be concentrating on the tobacco element. So the 3 indicators, tobacco screening. So we do, when any service users, as we call our patients, come into our services, they will be screened for their use of tobacco. Now, that doesn't only mean, do you smoke now? It also means, have you smoked in the past? Have you recently given up? Have you stopped and started? Never smoked. So it's recording all of that information. The brief advice, very brief advice. We do have an e-learning module on our intranet, but we also recommend using the National Centre for Smoking Cessation Training very brief advice module, and it's essential to roll for all our staff. This has been since we first started implementing smoke-free status, but also more recently for the purpose of the sequin, so that was already in place, and level 2 for all frontline clinicians. The level 2 training also incorporates very brief advice within it. The tobacco referrer and nicotine replacement therapy, when it talks about referral to smoking cessation specialist services, we do include in that for our inpatients, which obviously the sequin is for inpatients, we include in specialist services our staff that have been trained to level 2. So that's any registered clinicians can do the level 2, which again is essential to roles. So it can be doctors, but also nurses, occupational therapists, and so on. Also, the referral element of it, that's referral either to the level 2 when they're inpatients, but also referral to the local stop smoking services or primary care, their GP, on discharge. So again, as mentioned previously, it's important that it's recorded on discharge summaries so that they get seamless support when they leave us, that they receive the support, that they're given TTAs to take with them if they've been using NRT. But also you can see at the end there I've put plus varenicline. I was actually a member of the London Clinical Senate delivery group of their Helping Smokers Quit initiative, and part of the work of that group was to encourage the use of varenicline. Within mental health, it did used to have a caution attached to it, but that was lifted about 18 months, 2 years ago. So we're very keen that not only our doctors, it is prescription-only medication, as you're probably aware, but we're also keen that when people are stable and settled and well in the community, that primary care and stop smoking services should look at prescribing that so that they're actually non-smokers when they come into our services. And this would also be relevant to acute trusts for elective surgery that could be addressed before they're actually admitted. So I think that's very useful to encourage the use of varenicline. If we can turn to page 5, please. You can see there providers are expected to audit all patient records, so we have worked very closely with the divisions. We have 3 divisions within our trust, and the quality leads from those divisions, and also our IT support services. We've worked closely with them so that the case notes can be audited, and it includes all completed emergency and elective admissions, so i.e. all inpatients in both mental health and community services, with a length of stay equal to or bigger than 1 day within the last 3 months. If we can turn to page 6, please. Unique adult patient, the definition of that, it's a non-repeat admission of a patient. So we do sometimes get people coming back and forth. So it only be the one time they're admitted when they've received the interventions from the sequin within that period. And they should be at least 18 years of age because they're adult patients. So it didn't include our CAMS, our child and adolescent mental health services, nor maternity, and nor offender care. It includes the inpatient wards for forensic wards for offender care, but not, we also cover prisons, so it doesn't include the prisons. And also those who are admitted to an inpatient ward for at least 1 night. If we can turn to page 7, please. So all interventions should be recorded. Now, hopefully, I did send the smoking cessation care pathway that we produced to support staff in recording the interventions, initially for the purposes of going smoke-free to show how to improve health and quality of life and reduce the inequalities suffered by our mental health service users in particular. But for the purposes of the sequin, I've actually highlighted in red those elements that should be recorded to satisfy the criteria of the sequin. So hopefully you can all see that care pathway. If you can't, it is, I understand, going to be circulated afterwards and put on the website, so you should be able to access it, and hopefully that will help you. So the interventions that need to be recorded are the smoking status and history already mentioned, the offer of that very brief advice, which, as I said, we include that in our level 1 training, but also on the NCSCT website, it's CBA training. Any psychological support that's offered, so that's either on a one-to-one basis or as small groups on the ward. That we also have worked very closely with occupational therapists and activity coordinators, so it may not be on the ward itself, it may be in therapy centres where those smoking cessation groups can be offered. And then the referrals, as I said, we include both referrals to our level 2 stop smoking staff, but also primary care or the stop smoking services run by local authorities. And as you're probably all aware, some local authorities are now reducing or even getting rid of their stop smoking services altogether. So in that case, one of our boroughs had stopped their stop smoking service. So in that case, it's the case that they need to be referred on to their GPs and the national helpline. I've also included at the bottom there, we do find it very valuable to use carbon monoxide monitors. We use them purely for motivation, though, unlike in primary care where they need to be used for evidencing a quit. This is purely for motivation within our services, but we do find it very useful to encourage people to think about giving up smoking. If we can turn to page 8, please. The timeline for the sequin, as I said, we're coming to the end of our first year. So in the first quarter, we completed the information systems audit. We carried on with the training of staff. We were already well into training staff because of our smoke-free implementation. But we carried on with that and also collecting the baseline data. At that point, much of the data collection was handed over to our divisions, the quality leads within the divisions, who could encourage the staff within their divisions to continue completing the data. The successive quarters, as you can see, it's basically based on progression, to show progression. The second quarter, we did see significant progression, which was pleasing. We did find in the third quarter that perhaps the emphasis had sort of fallen off a little bit. Obviously, there's also pressure of work for staff, and perhaps things weren't getting filled in as completely as they should be. But also, we found that the nicotine replacement therapy provision had fallen, and we feel that was probably because e-cigarettes have been introduced. Our service users are allowed to smoke them, not smoke them, use e-cigarettes on the wards in their own rooms or non-communal areas. So we feel that that's possibly why the NRT provision figures have fallen, that people are actually relying on the e-cigarettes. But it remains to be seen whether that continues to be the trend when we get the next quarter's figures. If we could go on to the next one, please, page 9. The challenges that we found as we were implementing this, one of the biggest ones was the IT infrastructure. We were going through transformation of the trust-wide IT infrastructure at the time, and so there were various systems being used with different physical health records within those systems. So we had JADE, we had System 1, Safari, which was also used for the alcohol, and the learning and development systems. There were difficulties if people did the NCSCT training. We couldn't extract the figures from their database that our learning and development could use to show which of our staff had completed it. However, that's all being addressed. It's taken time, but we're gradually getting there. There were problems with engaging leadership, from top down basically, but also within the various divisions and boroughs, passing the buck, who was going to do this. There was some element of apprehension about sequin, and there was a need for all staff to take ownership of it, and for the leaders of the various divisions to encourage their staff to do so. Likewise, engaging with staff, as I've already alluded to, the pressure of workload on staff, and also on our acute wards, they can be very unsettled at times, and if there's a lot of agency staff, we found that caused problems because the agency staff may not have completed the training that's required. But the staff in general, there's the feeling of being dumped on, it's just another target we've got to complete things for. That is, to start with, that tended to be the reaction from some of the staff. But as time's gone on, people have engaged more. they can see the benefit, not purely because of the sequence, but as I said, we don't just look at the financial aspects, we look at the improving health benefits. And obtaining the data as well, we're reliant on other departments for that because there's so many different systems, and we're still going through the transformation process because it's such a large trust, that we do rely on other departments and other leads to provide this information for us. And then the protection of staff, which there were quite a few comments that, oh, it's just another target, you know, it's all to do with money. But there again, the money is useful for improving services. So this is what we try to, you know, emphasise, that yes, it is to do with money, but it's for the benefit of everybody within the trust that we can improve those services. So if we can turn over to page 10, please. They're looking at the benefits, the financial benefits I just mentioned. But as I said before the sequence, we were already stressing the importance of support for staff to improve health and well-being and reduce the inequalities suffered by many of our service users. And also not forgetting the community services there as well, that if people are coming in for procedures as inpatients, that if they can be supported to give up smoking, it's going to improve the quality of their health, their recovery also, so it can only improve their lives in general. And the engagement of all staff, it's not just nurses, as was mentioned previously, that all staff are included, so from management down, but also nurses, occupational therapists, physiotherapists, but also the care assistants who provide very valuable work. If they've all been trained as they should be, doing very brief advice techniques, then they can have that conversation with each of the patient service users. And if you really talk to patients, what I found is that most of them do want to give up smoking. The initial reaction can be sort of, oh no, I like my fags, or I want to carry on smoking, I don't want to give up. But a lot of that is because they're actually scared. They don't think they're going to be able to do it. They think it's going to be imposed upon them. And they do need that chance to talk about it, have that conversation. And we do encourage all our staff to do motivational interviewing training as well, so they can have the right conversation to support patient service users to really think about the benefits of giving up smoking, and you know, look ahead as well. Have you thought where you'll be 5 years from now, 10 years from now? What about your family? And most people, if it's not for themselves, they will want to do it for their children or their grandchildren, both to set a good example or because their children or grandchildren may have you know, studied it at school and got frightened that it is affecting their parents' or grandparents' health, and they're worried about losing them. So if you have that conversation, most people do actually want to give up. And that includes people with serious mental illness, which for many years it's been so entrenched within mental health that people smoke, both service users and staff. It is improving now, particularly with staff. Most of them have now given up compared to what it used to be like. But it's a long, slow process. So it's sort of very much ongoing work that we still need to encourage people to think about giving up. The referral onwards also, if we can go to page 11, where I'm saying partnership work and advice, I've already talked about the different groups of staff within the trust, but also working very closely with our public health colleagues in our boroughs, who are very supportive. We don't have smoking cessation services from public health in all of our hospitals. Some we do. It varies from borough to borough. But we do work very closely with them, and it's important, again, you know, the discharge summary that our service users can be referred on, so they do get that support within the community. I mean, the ideal would be if the national referral system or something like that could be rolled out nationwide, but obviously that's a huge challenge, and that would be a very long project. But those of you that do have access to the national referral system or Quit Manager would obviously be able to use those systems symptoms to refer onwards. So that's the end of my presentation. Hopefully I'll be able to answer any questions that there are when we have the question and answer session, and I hope you find the care pathway helpful, and good luck for the coming year.
Thank you very much, Mary, and thank you once again to Michelle and Julia. If we could give them a virtual round of applause, please, and we'll move on to the question and answer session. We're going to start with 3 questions that we've received in advance of the webinar, and we'll be recording this part. Whilst we're doing this, we're going to allow the message board to be open, so those of you who are on Skype who have got questions, you should be able to post those now on the message board. We'll then ask some of those questions and then move on to those of you on the phone. So these questions should be on slide 35 for those of you who had the slides sent out. So our first question is 9C includes a target for referring to specialist advice. However, has there been consideration for where a patient refuses? Trusts are not able to refer when consent is not given. Therefore, is unfair to be penalised where this is outside of a trust's control. I think, can I pass that one to you, Michelle, to start with?
Yes, happy to take that question. So I guess just to summarise quickly, yes, consideration absolutely was given to this when developing the sequin indicators. And certainly, based on the evidence, a trust shouldn't be penalised where a patient doesn't accept an offer. So the target for indicator 9C is that 30% of patients who smoke do accept the offer for referral and are therefore actively referred on for specialist support. So this particular indicator and the target is based on evidence that if all patients are offered a referral, then 30% are likely to accept that offer. But of course, being in healthcare settings where we do have that motivated audience who are keen to improve their health, we would actually expect that a higher proportion would be accepting that referral. So I guess this indicator does take into consideration that, you know, for many smokers it might just not be the right time for them to quit, or perhaps they don't want to commit to seeing a specialist stop smoking advisor. So that's fine, and that's why the indicator is at 30%. And of course, if providers do follow the best practice and offer every single patient who smokes a referral and also stop smoking medication, then we expect them to be able to achieve this indicator, and that is what we're seeing in mental health and community providers. So on average at the moment, the providers are actively referring about 34% of their patients on for specialist support, and that was a Q2 finding, so really early on, and we'll expect to see that improve even further over time.
Thank you, Michelle. As Mary alluded to, the next question's around disinvestment in local stop smoking services and how can we support patients who want to quit. I think we've got Kazim from the National Tobacco Control Team on the line. So Kazim, would you like to start with that?
I'm happy to take that as well, if that's easier, if he's on mute. Yep. So, I mean, I guess all of us would agree that locally there absolutely needs to be evidence-based support available for smokers who want to quit. And this need does exist, you know, with or without the sequin scheme. But I guess in terms of responsibility, it does sit with local systems to think about and make a decision on what support will be provided. So in most areas across the country, there are community-based stop smoking services to take on this role. And in a minority of areas where those services are being decommissioned, there are conversations happening around what support can be provided. So it's fine when the traditional approach of those community-based stop smoking services isn't being used at the moment, but there needs to be local agreement on how smokers will be supported. So Public Health England has published a tool. It's called Stop Smoking Services Model of Delivery, and that is available on gov.uk. And that outlines the evidence of different models of smoking cessation support that can be used locally to help facilitate some of that decision making. And I guess nationally, having worked with a lot of areas on this sequence, I can tell you that some solutions to decommissioning have included jointly commissioned services, stop smoking medications and behavioural supports that are being provided by a trained hospital member of staff, and also phone-based support. So both Greater Manchester and London have recently launched stop smoking services that are taking active referrals from hospitals. But for providers who do want to become self-sufficient in supporting smokers to quit, the NCSCT offer free online stop smoking practitioner training that can be used to train up their own staff in order to build that capacity within the provider to provide that support to smokers. But ultimately it is a local decision, and I'd encourage conversations about how best to provide that support to happen as early as possible.
Thank you, Michelle. The next question is, I think this is an open one, whether there are any areas who are building in additional activities to the sequin to ensure a more joined up approach. For example, ensuring that A&E admissions are captured and coded appropriately to drug and alcohol issues. Julie, I wonder if that's something that you've looked at within Southampton?
Well, because the sequin itself obviously isn't involving the emergency department, it's just inpatient. So in terms of an extension to that, we separately do work within the emergency department as part of our alcohol care team, and are looking at ways of improving their care there. The other thing that we've been able to do with our local commissioners is about getting an in-reach team, because we know there's a huge drop-off of patients who are referred on to community services who are just kind of told, oh yes, and there's this community service somewhere or other, go to it. We know that actually very, very few of those ever actually reach them. So one of the things our commissioners are looking at, have funded us for 18 months, to kind of demonstrate the effectiveness or otherwise of that, is that we have an in-reach service such that patients who are seen by our alcohol care team, be that in the emergency department or on the wards, are almost kind of, there's a bridge into the community services, with people kind of taking them there or arranging to meet them there, or, kind of facilitating them getting there. So I think that is a key thing. But the rest will be in terms of what local alcohol care teams are actually doing.
Thank you, Julia. Michelle, have you got anything to add to that, or Ian Armstrong, if you're on the line?
Look, I think I would just add that a lot of areas seem to be doing really positive work in terms of building in additional activities to the sequin to ensure that more joined up approach. So there's a lot of areas who are building the sequin into their broader MEC approach. Many providers who are extending the relevant activities to their maternity and outpatient settings, so having that kind of consistent approach where relevant more broadly across the organisation, and certainly, as Julia mentioned in her presentation, a lot of providers are linking in with GPs and making sure that information is going back in that way that joins the information that's being collected.
Right, thank you. So that's the end of our advanced questions. So we are now going to